You are listening to RX Radio in collaboration with the South African and International Pediatric Association. We want to welcome you to the Adolescent Health and Wellbeing webinar. Come mind the gaps with us when we discuss the issues around the teenage years, access to healthcare, and how we can support the youth better. RX Radio, by and for children.
Good evening, everybody. My name is Mignon McCulloch, and it is my absolute pleasure and privilege to be hosting this adolescent webinar tonight on behalf of the South African Pediatric Association, but also on behalf of the International Pediatric Association, IPA. But most importantly, we have had the privilege of being able to broadcast this from a real radio station, from RX Radio, which is based at the Red Cross War Memorial Children's Hospital. And I have real live radio reporters, and I'm going to be introducing you to Dr. Heloise Goodfellow, who is a pediatrician with a strong interest in adolescents, as well as Yusra, who is sitting on my left, who is one of the radio reporters, and you're going to hear lots about her, and also Talita, who is sitting on my right-hand side. And these are the real people who run this radio station, and we are very excited to be discussing adolescence. And so with that, over to Heloise, and she will be introducing everybody as they go along. So thank you to all of you and the audience for joining us. Thank you so much to all the speakers and participants. I think it's going to be a very exciting session. And over to you, Heloise. Thank you very much.
Good afternoon, everyone. It is my absolute pleasure to introduce our panelists this afternoon. Firstly, I'd like to introduce Prof. Ashraf Kovadia, who is the Chief Specialist and Head of Department of Pediatrics and Child Health at the Rahima Musa Mother and Child Hospital, where he's been working since February 1998. Then I'd like to introduce Prof. Ilona Tosca, who is an adolescent health researcher with a specific interest in adolescent sexual and reproductive health in resource-limited settings and how to support them to engage in safe relationships with peers and adult figures in their lives. I'd like to introduce Dr. Leslie Bamford, who is a pediatrician who also holds postgraduate degrees in social sciences and in public health. She's worked in child, youth, and school health chief directorate in the National Department of Health since 2006. Next, I'd like to introduce Yulisa Mfayise, a legal advisor and representative for the Human Rights Commission of South Africa. Very happy to have Yulisa. And then I'd like to introduce Dr. Mala Pandey, who is a principal specialist obstetrician gynecologist at King Dinizulu Hospital Complex in KZN, as well as the head of the Family Planning Unit. She has a special interest in adolescent contraception. Next, I'd like to introduce Tatenda Mawoyo, who is a qualified social worker, part of the Institute of Life Course Health and Research in Department of Global Health at Stellenbosch. His areas of interest include adolescent mental health, parental skills, and sexual and reproductive health. And lastly, I'd like to introduce Dr. Lelo Nkosi, a medical doctor from KZN. She is also a model, influential speaker, a businesswoman, events host, and also is the founder of Girls Network South Africa, which is an initiative that aims to empower and groom teenage girls and create a sisterhood for girls. And with that, we'd like to start with our first session.
Thank you, Heloise, for those introductions. So what's going to happen is we're going to be having our own radio reporters actually asking the questions. And so, Talita, I think you're up first. I'm going to swing the camera over to you. And you're going to fire away and start off with the first questions. And I think you're asking Leslie Bamford the first question. So go for it.
Good evening, everyone. As you said, I'm Talita Kanta. And my first question, well, let's say conversation. It's more like a conversation. It's to Dr. Bamford. Doctor, we'd like to understand better who the South African adolescents are, and what is the definition of an adolescent, as well as how big is the population of adolescents in South Africa, and how many adolescents have access to healthcare, and at which level do they get the access?
So good afternoon, and good afternoon to everyone on the webinar. So let's start with the first question. How do we define an adolescent? So generally, and there are sometimes people do use slightly different definitions, but in general, people would use the definition of any person who is between 10 and 19 years of age. And we know that in South Africa, there are about 10 million, just over 10 million adolescents, approximately equal number of girls and boys, or young men and young women. I think that the issue of where adolescents access health services is an interesting one. So in general, we know that adolescents don't generally come to our health services in the same way that children or adults might. We don't have great data, but we do know that about 8 million adolescents visited our primary healthcare facilities last year, or there were 8 million visits, just less than on average one per person. But of course, one person might have visited multiple times. But we also know that we reach a lot of adolescents in schools, because that's where they are, working with our colleagues in the Department of Basic Education.
Thank you so much for the question. Over to you, Yusra.
I want to swing you around. Yusra, over to you.
Good afternoon, everyone. I am Yusra Detoit, and I've also got a question for Dr. Bamford. So, what do we know about the global inequalities in adolescent health outcomes, and why haven't adolescents been a global health priority? Why should they be, and what exactly is the impact if we don't prioritize this group?
So thanks. I think that's a very interesting question. So I'm not going to, in the interest of time, we could reel off many statistics, which really do demonstrate that across a whole range of outcomes, there are huge inequalities across the world between adolescents living in high-income countries and those living in lower-income countries. Why have we not prioritized adolescent health? Perhaps for two reasons. I think historically in the health sector, particularly in child health, public health, we did focus a lot on mortality and morbidity, but particularly on mortality. And adolescents are actually a very healthy population with low mortality. And I think for that reason, we focus on other groups with higher mortality. However, increasingly, we have come to realize that adolescent health is a very important issue, both because, or maybe primarily because many behaviors that are established in adolescence really do impact on long-term health of the population. And so we've come to understand that if we don't invest in addressing adolescent health, ensuring that our adolescents, they might be surviving but not thriving, that will have long-term implications for the health and well-being and lifelong chances of adolescents. So it's really a chance to get things right, to make sure that our adolescents are thriving, and that we help them to be on a trajectory that will lead to a productive and healthy life.
Fantastic. Then thank you for that, Yusra. Then I think it's back over to Talita to do the next two.
So this goes to Dr. Mignon. and Professor Kavadia. So it says, so in the public sector, the physicians predominantly oversee the health of adolescents. And even though there's a slight variation between provinces, the healthcare is transitioned from provinces, from pediatrics to adult care at around the age of 12 to 13. And I've always wondered, how do doctors decide when do you cut off a patient? Because I'm 19, right? And I'm still a patient at Red Cross. And it's always the case when I tell people I'm still a patient, they always have this look, but why? Are you not old? And I'm like, I'm still a child at heart. Please. So doctor, can you please make me understand, how do you as doctors decide the cutoff age?
Ash, I don't know if you want to go first. Are you happy for me to lead?
You can lead and I'll follow.
It's a tricky question. I'm going to say that maybe some of it is financial and decided by politicians. I think it also depends on the size of the patient and their history. So like yourself, we've known you for a very long time. And sometimes young people have diseases that pediatricians may be more comfortable with dealing. We've become really good at looking after people with complex conditions. And so sometimes sending them to the adult colleagues, they struggle a little bit because they may not have heard about that condition. So we work very nicely together in that we actually try and do a transition program where I do a clinic here, but I also go and do a clinic together with my adult colleagues. And so we kind of say same face, but different place. We sometimes a bit cheeky. We say you'd be 12 years and 84 months. And it's something that we're all discussing a lot, because would you give your 12-year-old your car keys and your wallet? It's a bit tricky, but let's hear what Ash has to say, what happens in the north of the country.
Yeah, thanks very much, Mignon. And thanks for that question, Talita. So I've also been wondering where this cutoffs have come through. And I think it has been largely from a practical point of view, but it has had a negative consequence for teenagers. And the practical point of view is often this isn't decided by doctors, to be honest. It's more administrators, and I think from a nursing staff point of view, who actually have to manage patients in wards. So I'm talking about the inpatient side of things. Pediatrics, unlike in adult medicine, don't divide patients by gender. So you have males and females in the same ward. And often when we've wanted to have older children or adolescents in the ward, that has been the biggest resistance from management and from nursing, saying, well, you can't actually have a 15, 16, 17, 18-year-old male with all these other children and females, and so and because most hospitals don't have enough wards, we have all pediatric patients of both sexes in the same ward. So I think that from a practical point of view, most hospitals have settled around the age where they see 12, 13 as a child, and beyond that as now early adults. So there isn't a scientific way that they've decided on this. It's just, I think it's a practical way, but it has unfortunately negative consequences for adolescents.
And I think just to add to that, we're very lucky in that we work very closely with our managers, and I think everybody is struggling with this. Where is the best place for a young adult or an adolescent? And so communication and teamwork with clinicians and administrators and nursing staff really has come a long way, in that we've realized that certain patients are better served off in a pediatric hospital, possibly for longer, until everybody is happy that it's a good time for them to transition. And we always say never move somebody in a crisis, but we are very lucky in that we actually chat to our administrators as well.
Thanks so much, Chantal.
Okay. Good. Thank you. Heloise, I think over to you.
Yes. My question is to Dr. Bamford, to Leslie. You've already touched on mortality and morbidity of adolescents. Perhaps you can suggest how we can make interventions that will make a difference to their mortality and morbidity.
So with regards to mortality, we know that the leading causes of mortality in adolescents are really twofold. First of all, external causes of mortality, accidents, injuries, whether these are intentional or unintentional. And then secondly, infectious diseases, including diarrhea, pneumonia, also HIV and TB. So that's really talking about the mortality side of things that we would need to be addressing. I think what really the challenge with adolescent health is that one really needs to be providing a full package of support. That it's not just about treating diseases, if you like. It's that full package of services that looks at issues around nutrition, issues around sexual and reproductive health, issues around psychosocial well-being, so mental health issues, and then at the same time addressing some of the socioeconomic issues around job creation, issues around gender-based violence. So really, I think in our thinking, we need to be quite broad, and to recognize that the majority of things that young people need are not things that are provided in our health facilities, but are provided in a range of settings. Young people spend most of their time in school, so that's a very important setting, but they're also in their communities and in their homes. I think I'll stop there, but I think hopefully that's something that we can really unpack during the rest of the webinar, what that package of services should really look like.
Thank you. Thank you for your answer. My next question is to Yolisa. The South African Constitution states that everyone has a right to access healthcare services, including reproductive healthcare. SDG 3.8 also challenges countries to achieve universal health coverage. Is the Department of Health meeting these mandates, especially with the provision of healthcare to adolescents?
Yolisa, your mic is muted. Yolisa, your mic is muted. Thank you very much.
Thank you for that. Yes.
Perfect.
Thank you for that. Good evening to everyone, and thank you, Heloise, for the question. I might ask to switch off my camera because it tends to disturb the bandwidth a bit.
Perfect, no problem.
So when it comes to, thank you. So when it comes to the Constitution as well as SDG 8, I think, you know, the way our Constitution is worded, I think we can all accept by now that it's common cause that the word everyone in that section, the fact that it says everyone, you know, has the right to access healthcare. This also extends to adolescents, of course. But the thing with that particular age group, as we've heard, that we're talking about people who are in the age group between 10 and 19. And so most times you find that, you know, they don't necessarily always seek healthcare on their own. So they're either always accompanied by a parent, a guardian, a caretaker, and so on. But I think in as far as, you know, being progressive and realizing the fact that in as much as this age group is almost always dependent on a guardian of some sort, I think legislators as well as the Department of Health have tried to be progressive in the sense that they've enacted legislation as well as policies that ensure that children to some degree can exercise their own autonomy with regards to access to their own healthcare. Of course, we know that for instance, when we talk about you know, the choice to terminate, that it enables a child within a certain age to access those services. So that then gives effect for that right that is stipulated in the Constitution, and of course, it also gives effect to the SDG 8. And so, without trying to sound like the spokesperson for the Department of Health, but I think they, at a practical level now, when you move away from the policy and legislative level, and you then come to an implementation and practical level, they've made means to fulfill this mandate. So, for instance, one can access condoms at public places, including schools and institutions of higher learning. As I've mentioned, girls within a certain age group can access termination of pregnancy services, which don't always make it mandatory for a parent to consent to this. The Children's Act also gives children the right to independently consent to HIV testing, to male circumcision, to access contraceptives. And I think in 2017, the department must have acknowledged the fact that when it comes to adolescents and youth, they needed to have a guideline to their departments and organizations working with children on how to respond to the healthcare needs of young people by introducing the National Adolescent and Youth Health Policy. I think the challenge then starts, we start seeing the challenges as we zoom in to then assess whether, at a practical level, are we even close to achieving universal health coverage as it is anticipated in the SDG. And to do that, we then need to interrogate whether adolescents have access to the full range of quality health services that they need, when they need them, and where they need them. And this is where we start seeing the discord between what is legislated and in policy and what actually happens on the ground. So there have been efforts by the health department in collaboration with DSD and DBE, for instance, Department of Education, with the CS tool, for instance, but that has had its own challenges and its own barriers in terms of being successful, such as, stigma and discrimination, lack of skilled personnel is an issue. It is an issue even with access to healthcare for adults, and you can imagine even more so now for young people and adolescents.
Thanks, thanks, Yelisa. You've given us quite a lot of detail. There's actually a question in the chat from Shauna McGregor that I think would be nice for yourself and Leslie to answer. In terms of legality, is there an age restriction for when pediatricians should not treat patients who are early adults or late adolescents for both a known and a new patient? I don't know if you'd be able to answer those questions. Dr. Bamford, perhaps you could start.
Yeah, I'm not sure that I'm the right person to answer that question. My work focuses mostly on primary healthcare and district hospital level, and we don't really not really faced with that dilemma. But I'm wondering if one of the pediatricians could answer that. I see.
Yeah, maybe. I'll go first and then maybe. So I'm not aware of an age restriction. Remember, there's sometimes conditions in children that they grow older. For example, cerebral palsy, that are kind of pediatric conditions, developmental disorders that pediatricians are far better at managing than our adult physicians, who feel quite inadequate at managing a cerebral palsy patient who might be even 30. So I'm not aware of an age restriction. Minyo, I don't know if you'd like to say something.
I was just going to keep it short and sweet and say we've actually treated a 32-year-old who was less than 1 meter tall, who needed plasmapheresis for a neurological condition because the adults were not comfortable with the size. So I don't think there's a maximum age cutoff. But I think for the benefit of everybody, at some point you need to organize a good transition program. But I'm sure we're going to chat more about that. Okay, so
Thank you for your answer.
we are going to do the song. Oh.
I don't want you to go, 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 go. I don't ever go, 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 go. 'Cause I know.
Yeah, Yusra help. I think Yusra you should, because you know the.
So that was a quick little break, and we just had a song by Jimmy Nevis. Now we're going to move on to session 2, which we are going to focus on reproductive health and teenage pregnancies. So to start us off, Dr. Pandey, it feels like the teenage pregnancy rate in South Africa is getting worse. Is this true? And what is the impact of a teenage pregnancy on the pregnant mother as well as her unborn baby?
Thank you for the question, Yusra. So it's not that simple as a yes or no answer. I've got to put the data that we have available into perspective. So globally, teenage pregnancy is a problem, and it's not just limited to developing countries or low and middle income countries like South Africa. And what's very tragic is that adolescent pregnancy or pregnancies in the 10 to 15 to 19 year group is the second most common cause of mortality in girls. It's obviously more serious of a problem in developing countries where 12 million girls give birth annually. In South Africa, our data is not very strong. We use a proxy for teenage pregnancies in our country because we don't have every pregnancy reported. So we use adolescent births as a proxy to calculate our teenage pregnancy rates. And worldwide and in South Africa, at the turn of the century, so in the new millennium, we were seeing a decrease in teenage pregnancy rates. And this was a great trend until the last 5 years or so, where something happened and that trajectory has changed and the graph is now starting to go upwards again. It is quite worrying that 83% of girls in a survey in 2017 admitted to being sexually active, but of those, less than half were actually using contraception. And this is what creates a very high unintended pregnancy rate, which is dangerous because those pregnancies that are happening, they were not really wanted in the first place. Now, in the UK and the US, they also have a high unintended pregnancy rate. Globally, it's about 50% with young girls and adults. But in those countries, they have safe access to TOP facilities, which we don't necessarily have very accessibly in our country. So when you look at the data of what is the rate of adolescent pregnancies in South Africa, we usually quote the fact that about 11% of the total number of births in the country are to girls between the ages of 10 and 19, which is quite high. And there are some cross-sectional studies and surveys that have shown about 20% of adolescents have bared a child. The number that created a buzz in 2019 was that there was 106,000 registered live births to young girls, and most of them, unfortunately, came from my province. 24% were from KwaZulu-Natal. And this data created a lot of hype in social media, as well as resulted in a flurry of articles published in the medical journals. It also got the Department of Basic Education scattering to update their prevention and treatment of teen learner pregnancies in schools policy. So this number was worrying. And then what happened in the last 2 or 3 years is that number just continued to go up. And you can see that my next slide.
Sorry, do you mind just popping it onto a full view, not presenter view? Is that possible?
Okay, let's do that.
It's under display settings in the middle at the top there, Mala, at the top middle display settings. Not show taskbar, just this in the middle.
Middle.
Yeah, we can see it. It says display settings. Maybe it doesn't for you.
I don't see that.
Sorry,
Maybe I'll just end show. Would that help?
It's fine.
Yeah, just stop screening and reshare, but it's not the end of the world if you don't get it right. That's fine.
All right. How's that?
Perfect. Fantastic.
Okay. So you can see that in the last few years, that number continued to get higher and higher. And what was more worrying that is in the group of the 10 to 14-year-olds, the increase in pregnancies or births was actually 48.7%, which is very worrying. The increase amongst girls 15 to 19 was 17.4%. According to our demographic and household surveys, you can see as well that about 28% in the recent survey of girls at the age of 19 had already begun childbirth. But what's more scary again here is that you see that amongst the younger adolescents, the 15-year-olds, the percentage of girls that are have given birth to a child had actually doubled. So that was very concerning. So your next question, these slides. So your next question was about the impact of pregnancy on young girls. So pregnancy is actually a happy occasion. And usually it's associated with excitement for the birth of a new child and hope, but it also has a lot of dangers and adverse effects. And this is for all women. So adolescents will also experience these adverse effects. But more than that, there's additional problems when it comes to adolescent pregnancies, which are both physical and emotional and mental, as well as socioeconomic. So adolescents who fall pregnant have a higher risk of anemia, preeclampsia, pelvic trauma, because their bodies are not really fully developed to deliver a baby. All women who are pregnant have a higher risk of HIV acquisition. There's higher rates of poor neonatal outcomes for children, for adolescents who give birth, and they are at risk of rapid repeat pregnancy. So there's evidence even in South African studies that shows if a teenager has a baby, she's at risk of having her second baby as a teenager. And these girls tend to drop out of school. They have high rates of absenteeism. They don't perform as well as their peers in class. And they're exposed to bullying, ostracization, isolation, and stigmatization. They are also at risk of abuse, all forms of abuse, and suffer psychological disorders. At the end of their schooling career, whenever that is, they also are not as financially independent as women who have matriculated and have higher rates of unemployment. So there's huge impacts and dire consequences for these girls. I'll stop there.
You again. Yeah, thank you so much, Dr. Panda, and also for the slides as well. Very, very informative. So now we're going to go to Ilona Tosca. So who is responsible for the provision of sexual and reproductive health education to adolescents? And what is the role of the Department of Education in the provision of sexual and reproductive health education?
Thank you for that really great question, Yusra. And the answer to the first part is that we are all responsible for the education and the information of young people, not legally necessarily, but in our role as peer mentors, as providers, as researchers, as parents, as aunties, in my case, as adults in the lives of young people, because there's actually, you can tell us yourselves, but no one likes to know and learn in one specific way. So particularly in adolescence, it's actually quite common to receive and process information from many different sources. And in terms of responsibility, that's quite different from who is currently providing and who assures the quality of that information. So we need to be quite careful about ensuring that there's not a synonymous understanding. We don't just think sexual and reproductive health means encouraging young people to have sex, which a lot of people do think. So there is a lot of controversy around that. But thinking around how do we keep our children, you all, anyone safe, and safe in terms of understanding boundaries and consent, understanding how to stay safe online, including potentially cyberbullying, and then in terms of understanding choices and the timing of different actions, for example, having sex, a relationship, multiple relationships, and so on. In terms of the Department of Basic Education, there are actually several policies in place that provide, we're very good in South Africa to have good laws. So there's actually a very brilliant curriculum and a legal framework. So we have, on paper, it's all great. And through schools, all young people should be accessing and receiving, all adolescents should be receiving information that is age and life stage appropriate about sexual and reproductive health. And that is usually delivered through the life orientation curriculum. And the curriculum itself is actually really, it's based on international standards and it's very strong. Its implementation, however, does encounter quite a few barriers. This could be because teachers do not feel qualified, or they're not actually trained to cover some of the difficult topics. They may not feel comfortable to actually discuss those topics. And there's a lot of myths around it. Many of us fear that talking to adolescents about sex means that they're going to have more sex. And there is no evidence to that regard. In fact, if there's no space to discuss these topics with young people, they won't know where to get the right information and how to stay safe. I hope that was all right. Back over to you, Louise.
Hi, the next question is going to be to Dr. Pandey and to Lelo and Nkosi. The question is, what are some of the barriers to accessing contraceptive services among adolescents? And perhaps Dr. Pandey, you can start with answering the question, and I'll give Lelo some time as well to answer.
Okay, sure. So you can see I'm still deciding whether I'm a teacher or a healthcare provider, so I diligently made slides for all the questions. If you look at barriers to access, you can classify them into many different categories. And if I were to go through what the barriers were with the adolescent herself, is that there's a fear to reveal her sexual activity. And some adolescents think that, it won't happen to me because they're not having frequent sex. Many adolescents have poor knowledge and information, or their information is not evidence-based. Their high-risk sexual behavior is aggravated by substance abuse as well. They have, it seems like they have a fear of side effects of the contraceptives, thinking that it's going to do more harm, which is not reasonable. And they also, although have great access to social media, don't have much access to mass media where all the educational campaigns are happening. And we know that teenagers now are also starting their sexual debut much younger and younger. When it comes to educational barriers, education starts at home and then at school, and then when they seek help with the healthcare providers. And this education seems to have been more restrictive than comprehensive. But as you heard from the previous speakers, that the education is now starting to become comprehensive sexuality education rather than just plain biological sex education. So hopefully things will improve. Under the category of political, I think the government has done much, and there's many enabling policies. So there we're doing quite well in terms of making commodity freely available, increasing awareness with campaigns and using non-government organizations to to advertise for sexual reproductive health. So in that sense, we're doing well. When it comes to healthcare providers, and here it's a bit worrying, is that there seems to be, from a qualitative studies that interview young kids, they seem to not be happy with the attitude of the moralistic attitude of healthcare providers. And we also find that they lack skills in provision of all forms of contraception, and they have poor counseling skills. So this needs to improve. On a socio-cultural levels, there's also barriers, and you can read that off the slide.
Great. Perhaps, Lelo, could you also give some background as to what you feel is actually the difficulty with our adolescents accessing contraceptive services? Lelo, are you with us?
Hello, you need to unmute.
Sorry.
Sorry.
Hello, everyone. Just to add on to what Dr. has already mentioned. So I work a lot with young girls and students in tertiary, as well as with a lot of organizations reaching out to communities. And what we've picked up is the first thing that they normally tell us is that they are scared because the nurses, they're mean. So it's simple things as that when they want to learn about this, they feel like, oh no, that old auntie is going to say that I'm already sexually active. So they're always stuck between inquiring, whether they're asking about it, and regardless of their sexual activity state, they still feel that it will give a wrong impression or perception. So they always highlight that they're scared, but then them being scared, it's because that the healthcare sector, or rather the clinic itself, therefore to me rings as that it's not a safe space for young girls to actually inquire about such. So therefore we're also not becoming, as healthcare workers, we are not becoming educating to the young girls, but rather we are always just quick to treat and not prevent, and we're always there to blame. So they always highlight that they're scared, and also they believe everything they see on TikTok and Instagram. So I also think that as much as sometimes as healthcare workers, looking at our professional, it's a very thin line, sharing wrong information or giving the right information. Being it, we already have fake doctors trending than qualified specialists. So it becomes a bigger challenge. And I think that for young doctors like myself, using social media as an educational platform is really important. So they will come to the clinic asking all these weird questions and scary things about side effects of contraceptives. So I think that also them getting or reading wrong information becomes a problem. So they're always saying that they're scared. They come with TikTok evidence, and that also shows that I, as a doctor, am not playing my role significantly. So through my experience, I would say that it's those two things. But then if I look at a group of girls that's well informed, they make better, healthier decisions when it comes to contraceptives, and they are not scared to inquire about it. And also, the more they know about it, the more they read about it, or they're well educated about it, they feel confident and they're more enlightened to even share the information with their peers.
Thanks, Leo. Thank you for your
You are listening to RX Radio in collaboration with the South African and International Pediatric Association. We want to welcome you to the Adolescent Health and Wellbeing webinar. Come mind the gaps with us when we discuss the issues around the teenage years, access to healthcare, and how we can support the youth better. RX Radio, by and for children.
Okay, go for it.
Just to give everybody a bit of that radio feel, we decided to play a jingle over there. And so, yeah, at the moment, RX Radio is in a bit of financial strain. So just a little bit of background about RX Radio. I joined a couple of years ago. I think I was in grade 3 or 4, and I'm now in grade 10. So quite a while ago, and I can definitely tell that it has improved my self-confidence. Talita can say the same. It's improved all of the reporters, our self-confidence. We've got to share our stories. And my sister actually has a condition whereby she attends Red Cross Hospital. So I joined as support to join her to become an RX radio reporter, and we host a show together as well. So in order to keep RX radio going, and because it's a great organization, you can tell that all of our reporters love to be here, and we like a big happy family over here. So in order to keep the radio station going, we'd like to appeal to you to donate. So you can visit our website at www.rxradio.co.za. And 250 Rand donation could give us refreshments when we have our workshops. 500 Rand would better our equipment for the studio. As you know, radio equipment is quite expensive. And then a 2,000 Rand could contribute towards training a reporter and giving them the correct training for to become a reporter. So yeah, that's just a little food for thought before we go on to session 3.
And I'm just going to really reinforce that, because RX Radio is my favorite radio station. It's the only radio station run by children and young adults in Africa. And I'm just really, really proud of them, which is why I'm lucky enough to be sitting between the two of them. So take Yusra up on her offer. Right, over to you, Heloise.
Great, thank you. So our next section is addressing long-term health conditions, and my question is to Talita. Talita is not just an RX radio presenter, she's also a media student at UCT and a young woman with a long-term health condition. Talita, what was your experience of accessing healthcare available to you as an adolescent with chronic health problems? And do you have any messages for other adolescents with long-term health conditions?
Okay, so Red Cross specifically has always been my second home. And I know this sounds bad, but I loved visiting the hospital when I was young because of the nurses and the staff. They really made it enjoyable. And as much as I got, injected medication, nonstop physios, which can be quite boring, but I really, liked the experience. So living with a chronic condition was tough, but I made it, or people around me made it an enjoyable experience. And you wouldn't think that I was going to the hospital, but I made it as if I'm going to a fun place, and because I was used to the people around me. I mean, I was the patient since I was 6 weeks old, so it's been the only place I knew, which is quite sad because I might transition to an adult hospital. And regarding a message to an adolescent with a chronic condition, I don't have much to say other than live your best life, live all your dreams, and don't let people kind of tell you that you're not allowed to do a certain thing because you have a condition. But also don't put your life in jeopardy because of what I said. So do what makes you happy, and realize that you are who you are. Your condition doesn't define you. It just makes you even more special.
Talita, that was so beautifully answered and very, very inspiring. We're going to move a little bit ahead, and I've got a question to Mignon and to Prof. Kuvadia. We can see that we are perhaps not doing the best job at transitioning care for long-term health conditions, and perhaps it's something to do with our education as pediatricians and doctors. So we understand that adolescents, and we can hear from Talita that they're a unique group with unique challenges, and we don't feel that we're getting sufficient undergraduate and postgraduate training on adolescent care. How do we improve our training so we can improve our services?
Ash, do you want to go first?
I think I'll let you go first this time. Mignon?
You are absolutely right. I think we need to look at the age, and we've mentioned that in Sweden, 25 is the cutoff. That's a bit extreme, but possibly we should be looking at 16. But we definitely need to be training our staff, not just the doctors, but nursing staff and allied health as well. And so we have a renal clinic that runs at Reproductive Hospital, where we have actually got young adults, patients, who've become our young adult mentors, and they are actually supporting the patients, but they're also supporting the doctors who work in that clinic. So I think that's really amazing. We've also got our first adolescent doctor who's a pediatrician who actually runs the adolescent ward, so a separate ward at Reproductive, and we have juniors, registrars, and SHOs and MOs who rotate through that ward and learn about adolescence. So I think that's really important. UCT's also just introduced their first adolescent diploma. So I think that's amazing. And Heloise, I met you on that, so that was really lovely to meet you. But I think this needs to be in our medical schools. I think we need to actually learn it from early days. And most pediatric departments around the country are called child and adolescent health departments. And so we really need to put our money where our mouth is. And I would say use our adolescent patients to be our teachers.
Thanks, Mignon. Prof. Kovadia?
Yeah, I couldn't agree more with Mignon, Prof. McCullough, that this is poorly taught at medical school, both for undergraduates and postgraduates. Many of you probably on the call will know that I ran a poll yesterday asking pediatricians now how they felt about how comfortable they were with skills managing adolescents, and almost 100% said they didn't feel adequate. And these are people who are specialists for the most part, or trained to be specialists, and this is across the continent. It's uniformly a feeling of insecurity or not being confident about managing adolescents, and it's not hard to understand why. It's just that in our curriculum, both at undergraduate and postgraduate level, it's not given enough attention. So how do we address that? Well, I think it's the points that Mignon raised, and I like what Mignon said. Actually, it's the adolescent patients that will teach us what they need as in that subspecialty, and we need to somehow increase the exposure of our trainees, both undergraduate medical students and other healthcare professionals, nurses, allied professionals, etc., to the adolescent population, which is it's a difficult population if they're outside of chronic conditions, right? So the chronic conditions, like whether it's renal or HIV or cardiac, etc., are within hospitals. But there are many children who don't have chronic conditions that have adolescent problems, but don't come to hospital. And that's the challenge. We've got to find how we can expose medical trainees, undergraduates and postgraduates, to that population. So it does require us to think outside the box of how we actually going to get the two together so that we can train ourselves and learn how to deal with adolescent issues. And the other thing I want to say is how we actually do that across disciplines. So not just pediatrics, also talking to our obstetric and gynecology colleagues, our adult colleagues who there are going to be a lot of adult internal medicine colleagues who also have an interest in adolescence. So we've got to find that mix.
Mignon, you had something you wanted to add?
I know we're running short on time, but Zakira Sablé is our adolescent advocate pediatrician, and she's put a lot of stuff in the chat group, so write to her. And also really grateful to all the people on this call. So we need managers, administrators, you need gynaes, you need physicians, you need, as they say, we need to learn about sex, drugs, and rock and roll, because that's what our adolescents are exposed to, and including social media. So really thanks to everybody on this call, because it's the way we need to move forward. Thank you.
Great. I think maybe in the interest of time, should we move forward, Mignon?
Yep, happy to do that. Who's up next? So, you now, go for it. Okay. So, Louise, you
I'll go for it, yes. So there's a question to Talita and Ilona, just briefly. Perhaps you can give us a big strong, bold message for us. What do adolescents need from doctors and healthcare providers in a consultation? Now, strong message. We've got all these doctors listening to you, Talita.
I think Professor Kovadia mentioned that you can learn from adolescents as a patient. So doctors and healthcare providers can learn from a patient. And I believe that if I am told by a doctor what is going to be done to me, and I have, the right to give ideas or to say, no, but I don't want it a certain way. Can we do an alternative? Because an adolescent is a person transitioning to an adult, right? So as an adult, you should be given choices and not being made decision for because you're still a young person. So I think that healthcare providers and doctors should allow patients or adolescents to make decisions about their health, but also make them understand that the decision they take could be right or wrong.
Beautifully answered, Talita. I think we all needed to hear that message.
I wish I'd gone after Talita, but Talita, just most of us, because that was very beautiful. But I think you've highlighted some really big points that we also have heard from a lot of young people we interview. I'm a social scientist and I run cohorts with adolescents, so thousands of young people. And when we do quantitative analysis, in almost every analysis we do, how young people feel they're treated in a facility is one of the strongest quantitative predictors of their HIV or SRH outcomes. And it's not necessarily that they're getting shouted at, but if we treat them like, Talita, you should really listen to me right now. Stop having sex or stop smoking, or sorry, to use it as an example, the way the young person hears it and the way the adolescent brain hears it, and that's where courses may be quite useful, is very different because we're all stuck somewhere between adolescents. Are they big children or little adults? And they're actually a little bit of both and neither. And it's part of the adolescent brain to take risks and make mistakes because that's the only way that it learns and can become the adult that we all want to do. So they can't learn by being told. So having choices and having those choices explained, not feeling shouted at and feeling respected, but also not assuming that a doctor can save and do everything. So what we find from a more social science, holistic package perspective is that linkages to other services are quite important. So not just specialist care of different kinds, but maybe sometimes one needs a social worker or another kind of non-medical care, and making a link to that is quite critical in this life stage. Thank you.
We are on session 4 now, and my question goes to Mr. Mawoyo. So with regards to mental health, many people are struggling, even more so for our youth. Mr. Mawoyo, why is this period so tough, and what support is available for adolescents in helping them through this phase? And is it harder to be an adolescent today compared to 30 years ago?
Thank you very much for that question. So just to look at why is it so tough being an adolescent, I think one of the things is that there's a lot of physical, cognitive, emotional, and social change during this time. As pointed out earlier, we're looking at the period of 10 to 19 years. And so there's a lot of development that's taking place during that time. And from a mental health perspective, we find that about 50% of mental health disorders have their onset from about 14 years. So it's a really critical period, this period of adolescence. And touching on your second question in terms of, is it harder to be an adolescent now as opposed to 30 years ago? I think it's a very difficult question to answer, but one of the things is that the challenges are different. And I think right now, the challenges that adolescents are going through are quite complicated. So for example, we've heard many speakers speak about social media and the influence of that and the amount of pressure that puts on adolescents that is extremely stressful and obviously then has an impact on their mental health. Similarly, we know that adolescents spend a lot of time in school, And we know that in South Africa, for example, bullying is a very big problem. So these are some of the challenges that the adolescents are going through at the moment. And if you look at maybe 30 years back, perhaps those challenges would have been different. I'll leave it there for now. Thank you.
Thank you so much for the answer. Another question to you, Mr. Moyo and Dr. Lelonkosi, is it's hard it's hard from a mental health perspective to be an adolescent, but for an adolescent who is part of the LGBTQ community, it could represent many challenges. How would you advise an adolescent who is in the LGBTQ community to access support? Dr. Lelo, would you answer first, please?
Oh, okay, thank you for the question. This is a very tricky one and a bit hard when it comes to, especially because of the stigma around the LGBTQI plus community. But I would like to say it starts in schools, especially in rural areas. We actually have what we call LSAs, which are the learner support agents. And I know quite of a few. These are people who are basically just trained lay counselors, and they strategically placed in certain schools, if not all, hopefully by now. So this is like an integrated solution with the Department of Education, together with the Department of Health, Department of Social Development, as well as Home Affairs. They are trying to come up with better ways and solutions in how to help communities like the LGBTQI. So I think that it's important for communities to be aware of such individuals who play this role. And then back to school, simple things like our LO teacher. I remember mine very clearly. And I think that if our life orientation teachers, they are taught to be more proactive, more active, and practical when it comes to the life orientation subjects, I think that they'll also play a significant role into assisting in such matters. Growing up, I grew up in Mandini, Sundumbili. I was one of the peers in Life Center. So we have, we still do have, though now it's less of physical structures, but it's more on online platforms. So we have, centers like the Life Youth Center, where they have a nice online chatting platforms for the youth at large. And I think that it's important for us to be well informed about such programs. So I would really encourage them to access such platforms. And even in tertiary level, we still have programs for peer educators. I, for one, was a peer educator myself, though primarily such initiatives were focusing on HIV, on raising HIV awareness. But now, as time went on, they focus not only on HIV, but HIV-infected people and the LGBTQI plus community as well. Thank you.
Right, over to Heloise. Hey, thank you.
Great, thank you. To Elona, it's quite a meaty question, so I'm not quite sure if you can perhaps briefly maybe just discuss something in short about the social determinants of health in adolescents with regards to policies pertaining to this group. Yeah, sorry, can you hear me? Yes. Are there any policies that you feel need to change? Is there anything that strikes you as a big issue that we could change that's quite a big problem?
We have a lot of policies in South Africa, as I mentioned earlier, and quite a few of them are fairly visionary. For example, we have a new, and I'm going to mess up the name, the policy for the prevention and management of learner pregnancy. It's a DBE policy that builds on the integrated school health policy, which is currently being reviewed for the next 10 years. And the school health policy is the one where DOH, the Department of Health, Department of Education, and Social Development come together for a package of care. One of our challenges, I would say, is actually implementing these policies and knowing that what we're doing is the best way to actually do the work. However, there are areas that we could have some clarity. I've been following the chat where we can have a bit more clarity on how the policies are implemented, so more operational guidelines. And when it comes to adolescents specifically, sometimes legality gets in the way of actually providing adolescent-centered care. So if the guidelines, for example, focus on, let's say an implementation around violence and violence prevention or related topics, if the goal is figuring out who had sex with whom, how old they were, rather than actually thinking, how are you doing? Is the risk still there? Do I need to get you immediate care? Which is often what our legal frameworks start with. It's figuring out if there is a legal risk to the provider. That I would say is an important shift to consider to provide adolescent-centered care. And I think in another area of implementation is actually just understanding a lot more about our young people with better data. So at the moment we have data for under 15s and data for over 15s. And just having more specific age group data would actually help us all in the policies. Over.
Great, thank you so much. Over to you, Yusra.
So our next question is to Yolisa, and basically the future for adolescents from an economic perspective seems bleak. How do we create hope for adolescents in South Africa, and how can we protect and advocate for the rights of adolescents? What are the advocacy groups, and NGOs supporting adolescents in our country? I think the mute is still on.
Sorry, Yolisa, your mute is on.
I always forget to unmute.
Fine, all good.
Thank you so much, Yusra. I'll start with the question around how do we create hope? And I think listening to the conversations, there's a common response to this, and Talita touched on it quite extensively. The fact that I think most of the times when we speak about young people, when we speak about the youth, we always do so from a perspective of what can we as the adults do in order to make things better for them, for young people. What we always obviously move from the premise of what's in the best interest of the child through the lenses of the adults. But we seldom ask these questions from the young people themselves. So I think we can start by including young people in formulating the solutions that affect their future. So encouraging young people to adopt almost a nothing about us without us approach at all levels and in most things that affect them. And for us as the adults who are either formulating policy or, ensuring that they have access to economic activity and their education, moving from the premise of nothing about them without them. And I think just at a basic level, it really starts in terms of creating hope. It begins with each of us. I think all of us who are in contact in some form or another with young people, with children, because I think in most times, like just as with anyone really, we all want to feel seen, to feel heard, and to be understood. And I think we can all do that to each child that we encounter. And, in that way, we give them hope, we give them something to look forward to. And also just going back to basics in terms of keeping young people active, keeping them involved in programs that encourage them to unearth their skills, their talents, their interests. Because I think the way in which, there's so much responsibility that's placed on them. There's so much that's happening in the world. There's so much that's happening in the news cycle. They also absorb a lot of this, and then they end up with feelings of hopelessness and helplessness. Whereas when they have something to look forward to, if there's a community program that they can go and look forward to, it helps build the hope for their own future, and they can begin crafting their own future and having a sense of what it can look like. And in terms of how do we protect and advocate for the rights of adolescents, I'll speak here just briefly of, I'll make examples of the work that the South African Human Rights Commission does. So the work of the commission, we have various commissioners, and their work is really centered around various rights in the Constitution. And obviously one of those is children's rights. And that means that we then have a commissioner that is dedicated to focus on children's rights. So it's one of the focus areas. And what that focus area does, its mandate is obviously aligned with the mandate of the institution, is to monitor, to promote, and to protect the rights of children. And that focus area does that work through collaborations with various institutions and NGOs. And an example of how they've gone about fulfilling this mandate, for instance, is a project that the Commission has done with the UN Children's Emergency Fund, where they went around the country across the provinces to actually monitor, for instance, whether the rights of young people were protected and promoted in homes, in children's homes. So they went as far as checking whether they had the correct dietary requirements, whether those were met, whether in the instance where children needed access to healthcare, medical care, how that process was managed, whether their right to education was being upheld, whether the environment was a child-friendly environment, and so on. And I think, because of the fact that we have a national footprint, we obviously can't get to each and every part, as I said, but in collaboration efforts, for instance, we collaborated with NGOs and CBOs in these provinces. And just to share briefly on some of the findings that was made in this instance, it became clear, for instance, that in a province like the Eastern Cape, it had the worst cases of children literally dying of malnutrition. The healthcare system, which is obviously already overburdened, was even worse so for children. There were reports of children that were dying on the way to hospital. And so when you,
sorry, I'm gonna have to stop
there's
time.
Okay.
Very much for that. Okay, and Heloise, back over to you.
Okay, so just in the interest of time, I think we're going to skip forward to the last question, which is to the panel. And it is about what can we change? Can everyone on the panel give us one thing that we can think of that can change the trajectory for adolescent health in South Africa? Perhaps just a brief, strong message, starting with Mignon.
Great. So when I grow up, I want to be a radio producer like the two ladies that I'm lucky enough to sit between. So that's my dream when I grow up. But one thing we can change, I'm very keen that SAPA, South African Pediatric Association, starts an adolescent interest group. So I'm putting it out there. I know Ash is also very keen on that. So please write to us if you are interested in that, because I think this is a way that everybody can get involved. So that's my two pennies worth.
Okay, over to Elona. Last message.
I'm very biased here, but I think we could do a lot more for adolescent mothers and stop punishing them for having children, which is actually what we do, because then we're having a double impact on them and their children.
Okay, lovely, strong message. Lelo, do you have a message for us? Just to unmute yourself, Lelo.
Okay, I would focus on us healthcare workers. I would wish that the healthcare workers, we create safer spaces for adolescents, where we create a space that's more supportive, safe, accessible, equitable, and non-judgmental. I think we'll have
Wonderful.
a better environment like that.
Thank you so much. Mala, Dr. Pade?
Okay, so coming from the healthcare side of things, I think, well, I would like to say I wish I could wave a wand and get all healthcare providers to remember that they must care and offer respectable service, but I can't do that. So from a realistic point of view, it's glaring from this panel discussion that we need to put existing policies into practice. There's too many policies and guidelines. Let's start practicing. And one example I can think of that will not cost a lot of money and is easily doable is to concretize networks between schools and the local primary healthcare clinic. So let the school and the school kids know who the operational manager is in the clinic. Let there be a link where they can offer comprehensive services, including HPV vaccinations, contraception, and crisis care in terms of rape. I think if we can create that collaboration, we can get a lot done. Thanks.
Thank you so much. Mr. Mawoya, do you have a last message?
Yes, I think from my side, it would just be, how do we support the people that support adolescents? So for example, how do we give support to teachers? Because if we are able to support teachers, they perhaps are able to pick up on some of the red flags before it becomes a bigger issue. And how do we do the same for caregivers as well? So supporting the people that support adolescents. Thank you.
Excellent. Thank you so much. Yulisa, do you have a last message for our audience?
I would include young people in matters that affect them. Thank you.
Great. It's a nice, strong and very important message. And then lastly, Prof. Kuvadia.
Okay, because I'm last, I can have two, right?
No.
Okay. So, I mean, we all have a role to play. And I'm trying to think of what is it from my vantage point that I can do. And I think that what I sort of pledged to do, and I think that what I'm able to do is actually bring the academic departments, the heads of the pediatric departments together so that this does get elevated as a campaign that needs to be driven. But it really needs to have a very deliberate plan, like what Prof. McCullough said, through SAPA with a sub-interest group, but actually have some, it has to be a project that has to move forward now. And the second one I would say is more of a personal one, is that in my own tenure, I'd like to see a chair of adolescent medicine at WITS. So yeah, that's what I hope to do, because I think it's long overdue.
That sounds very exciting. Unfortunately, you weren't the last one. I skipped over Dr. Bamford. So, Dr. Bamford, do you have a last message for us?
Well, I think I'm also going to sneak in two, and I think they've also been touched on. I think we talk a lot about prioritizing adolescents, but as ever, it's putting our money where our mouths are. And then secondly, working across sectors and with all stakeholders. I think our colleagues in education have done a lot of work. They've got a lot more to offer, but it is about having those partnerships and working together to the benefit and of adolescents. Thanks.
Thank you so much. I think I'll hand over to Mignon to close our session today.
Great. So I think I'm just going to ask Yusra and Talita just to thank the panel.
Yeah, thank you so much and for giving us this opportunity. It's been very insightful to talk about all the topics, all the sessions, and also as an adolescent and as a teenager, I feel like we are overlooked a lot, and I feel like it's very important, and I'm glad that there are organizations and there are people, doctors, professors, social workers that want to prioritize us and want to speak about these problems, because oftentimes older people speak on behalf of us, and I think it's very important. Yeah, and just to add something about RX Radio again, for everyone viewing, just remember www.rxradio.co.za, and any donations are welcome.
She said everything I wanted to say, but yeah, thank you for the opportunity, and I hope the audience also learned a thing or two about this webinar that we had. I really had fun.
Yeah,
it was very insightful.
Yeah. Great. And just a big thank you to Mativieja for putting this all together on behalf of SAPA. She has really got some inspirational ideas. Thank you to everybody for taking the time to listen. Zakira, we see your message. Visit the Adolescent Center of Excellence in Cape Town. and we look forward to seeing you guys again.
You are listening to RX Radio in collaboration with the South African and International Pediatric Association. We want to welcome you to the Adolescent Health and Wellbeing webinar. Come mind the gaps with us when we discuss the issues around the teenage years, access to healthcare, and how we can support the youth better. RX Radio, by and for children.